great to have more drugs in pancreas cancer. We recognize this is for a somewhat niche population, but a very important population of people with this disease. And one of the themes going forward will be how to build on this in terms of combinations, and to see whether the use of PARP inhibitors might apply to patients who don't have a BRCA1 or BRCA2 mutation, but for example have other DNA damage repair DDR gene mutations, and there's some suggestion that they may be a group that could be enriched for benefit. We also know that people who have somatic BRCA mutations, not as common as germline, germline being about 5 to 7%, somatic 3 to 4%, that's probably a little generous even, but that's an important group as well, and these mutations can equally predict for a value for olaparib as a maintenance approach. I would say one very important point to think about when one is considering using these drugs: don't wait until the disease is progressing. We know that people who are progressing on platinum therapy, or the cancer is progressing on platinum therapy, that appears to have a high surrogacy for resistance to a PARP inhibitor. And I think the sweet spot right now is disease stabilized and responding on frontline treatment, and then thinking about bringing in a PARP inhibitor as a way of de-intensifying treatment and offering more flexibility, and of course offering the potential for control. And the nice thing we see about PARP inhibitors, when they work, they can work really well. And in this patient population, sometimes for an extended period of time, measured in a number of years, right? And that's not a usual thing we're able to think about or say about this disease, not for everybody, but for a subset.